Hello, everyone. Welcome back to the Physio Almanac. This session is on the objective assessment, that is the part three of the musculoskeletal assessment series that we have been doing. So, just to give you a brief recap, we have presented the hypothesis to the examiners. Then we have collected our equipments, washed our hands, and we have gone inside to see and meet our patient. We have done the subjective assessment wherein we have asked questions about what the patient's main complaints are, history of presenting illness, past medical history, clear the red flags, and discussed about the patient's goals. Then is when we start with the second part, that is your objective assessment, which we are discussing today. In the objective assessment, there are three components, that is your observation, that is your looking, palpation, that is your feeling or feel, and examination, that is you are moving the affected joint and the joint above and below. All right, let's begin. In the observation component, you are only observing. As the name suggests, you are not touching the patient, but a good idea is to take consent for the patient again when you begin with the objective assessment. So I would say something like this: Thank you for providing me with all the information, Mr. A. We are now going to be starting with the second part of the assessment, that is the physical examination, in which I would be having a look at the affected area, seeing how your movements are, and it would give me a better understanding as to what areas are affected and how and where we should pl- plan and direct our treatment. Is that all right? Are you happy for me to proceed? Yes, that's all right. Okay. Thank you for giving me your consent. Let's begin. So, this is something that you can tell to the patient. Now, so I'll just quickly tell you again. We have taken one consent at the beginning of the session when we are just starting to talk. Second consent before you start the objective assessment. And I'm telling you now, we will take another consent before we touch the patient. That is in the palpation component, just before that. All right. And I'll talk to you more about it when we move to the palpation component, but let's focus on the observation part first. So, in the first component of the observation is your posture assessment. Now, be mindful if it is a female patient and the physio is a male, make sure you do not make the patient uncomfortable. Well, it goes for the other way around as well. A male patient being seen by a female physio, but make sure most of the times it is the female patient and the male physio. So make sure that you do not make the patient uncomfortable. Just tell them that now we will be beginning with the observation component, and in that the first thing that I need to do is have a look at your posture. So what I want you to do is I want you to sit up nice and straight, as comfortable as you can be, and I'm just going to have a look at your shoulders, your head position from the front, from the back, and from the side. All right. So the patient, you've already told the patient, instead of just hovering around the patient and making them feel uncomfortable. So you've already told and verbalized this to the patient. Now remember, the assessors would be sitting at the back and they would be observing everything. So imagine you just stand up and you start hovering around the patient, and the assessors are also surprised, and the patient is also surprised as to what is this physio doing. So do not land up in such situations. Make sure to verbalize, make sure to tell as to what you are going to be doing. All right. So if the affected area is your upper limb, so you are just, it's okay that you just assess the head, the shoulder levels, and maybe elbows, and if that's required. If it is the lower limb, then obviously you cannot assess it when the patient is in sitting, so you will have to make the patient stand up. All right. Use your common sense, make the patient stand up only if you know that the patient has walked to the clinic, and do not make him stand up before you do a strength assessment if you do not know how the patient has come here. And how would you know that? Because you have already spoken to him in the subjective assessment. So you've already asked him so many questions that it's very clear that the patient has probably walked, or you have an indication that he already has this much of strength. All right. Okay, so let's say now you need to assess the lower limb. So you would just say, all right, I need to have a look at the levels of your knee, your hips, and your ankles. So what I would want you to do is I want you to stand up so that I can assess that. Is that okay? So the patient stands up. Now, also remember, other than the strength testing, if there is any walking aid that you need to position that in front of the patient before you stand him up, please make sure to do that. So do everything as you would normally, just being careful about what your purpose is. Your purpose is for posture assessment. So you are going to be making sure as well that the patient is safe, right? So that if that means putting the walker in front of the patient, do that. Or if that means that you do not know how the strength is, do the strength assessment first before you make the patient stand up for observation. All right. Now, the next thing is looking at the redness. So redness, swelling specifically are indicative of your signs of inflammation. So we are looking at these signs. Let's say if the patient has had a flare up of his arthritis. So we are looking at these signs, whether there is anything concerning that needs attention, or that is probably an indication of inflammation. You are also looking for bruising. Let's say the patient has had a fall and you're looking at the affected area and which appears to be bruised. You're looking for skin discoloration, or trophic changes also would be included. So let's say the patient has had a fracture of, I don't know, maybe the elbow, or just the lateral malleolus or the medial malleolus of the ankle joint. So what you are doing is, when the plaster of Paris, the cast is removed after a period of 6 weeks, say 6 or 8 weeks, when you it's just the first or the second day when you remove the cast, you would see that there are a lot of skin changes, and it's mostly related to dryness and uneven skin appearance. And it's just because the patient's affected area has been in the cast for such a long time. All right. So we've already talked about swelling. So you would be looking at edema. So I'm sure all of you are well aware it is different. If we are talking about swelling, it is in a particular area. Edema is usually widespread. Swelling is usually as a result of some injury. Edema may not be as a result of injury. It can be position dependent. It can be related to heart issues. And it is very common in older patients. Swelling is usually not widespread, and it is localized to that area. And the history would tell you that the patient has had a fall, or um, has had a sprain or something. So it's very clear differentiation there. All right, we look at deformity. So when we are observing the patient's, let's say, tennis elbow case, right? So we are looking at the area around the elbow, we are looking for swelling, we are looking for deformity, whether, and again, we are comparing it from the right to the left, or left to the right, whichever area is affected, you always compare it to the opposite side. And again, verbalizing. So all right, I am now going to be looking for around your elbow, around your left elbow, which is the main concern for today. And I'm looking for a swelling. I am checking if there's any deformity. Now, the in the exam, these patients are actors, right? So you would not be observing anything. If it's a real patient, then obviously you would be seeing swelling, and you would be seeing deformity and or mm, redness or bruising. But these patients who are actors, you may actually not be seeing anything, but again, you have to verbalize and we have to compare to the opposite side. When it is a simulated patient, we are going to be doing everything as we would do in a normal patient. If a patient has come to see us for the first time, everything that you would do if it was a real patient. So keep that in your mind. All right. We would then be checking for the walking pattern assessment. Now, again, if the patient has walked to the room and obviously you have not seen them walking, so it would be a good idea for you to walk the patient. Now, you will have to move the patient from the chair to the plinth. Now, let's say the patient, when you moved in, when you came to the room, the patient told you, no, I'm feeling a lot of pain in my back and I cannot sit for long. I want to move to the plinth or to the bed. All right, that's okay. So you've already changed the patient's position. Do not start assessing the patient at that time as soon as you move in, because you have not done the subjective assessment, right? So let's say you've already moved the patient. It's okay. You finish your subjective assessment and then you would say, all right, now I really want to see how you are moving and walking about. Is it all right if you are able to sit up and then maybe walk a few steps in the room so that I can observe your walking pattern? This is one case. Second case, the patient is sitting in the chair or the wheelchair, and you say, okay, we have done the observation component a bit. Now I want to check how you are walking. So, is it all right if you stand up and take a few steps within the room and then move to the plinth? Is that okay with you? So, you tell the patient, all right, and always ask, right? So, what we are doing is we are checking how the patient is walking. So let's say that it's a case of patellar dislocation, right? And the patient was in a wheelchair, the patient has been using crutches. So the patient is using two forearm crutches. The patient is sitting in a wheelchair, and you tell the patient, okay, I want to see how you are moving. So is it possible for you to stand up and take a few steps in the room and then sit down on the plinth? So the patient says, yes, that's okay. So now your assessment starts. You are observing how the patient is sitting to standing, how the patient moves about taking the crutches in his hand, how is the patient's gait pattern, whether the patient is leaning too much onto the crutches, and whether the patient is walking on his toes, whether the patient is having a heel to toe pattern, whether the knee is bent. So everything that you would do in a normal gait assessment, and these are the basic components that you should be assessing. And observe for any deviations. You know what the normal gait pattern is, you know what the normal walking pattern is. So assess for anything different, assess for any deviation from the normal. All right, and let the patient walk. After you've made the patient walk, and if you want them to lie down on the bed, so you would just say, all right, that's good, thank you so much, can you please now sit down on the plinth and I will talk to you about what I have found. So then you would say that the patient sit down, then you would tell about, okay, this is how I observed how you were sitting to standing, this is how you used your crutch, and you were probably leaning too far forwards, you were not walking on your heels, you had your toes up. So things like that, whatever you observed, whatever is different from normal, you will have to verbalize. Or in fact, if everything's normal, just say, yep, it's all looks good, there's nothing that I'm worried about, everything's fine. Now, Ottawa rules, I think we did talk about this in the hypothesis. So let's say if the patient has come to you directly and if he has not gone to the GP or any other medical practitioner. So you would have to check for the Ottawa rules. And one of the components, the ankle and the knee, one of the important components is, has the patient taken 4 steps, or was the patient able to take 4 steps after the injury? So if the patient has just come down in a wheelchair, so you would just need to tell them to maybe stand up and take a few steps, so that you can assess what's happening, right? Okay, balance assessment. Single leg stance, again, this will not be required for all the patient. Maybe, let's say, ankle sprain cases, because when you have an ankle ligament injury, there may be cases wherein your proprioception is affected. So that means the balance may be affected. And in the initial days, let's say the patient has had an ankle sprain yesterday and he comes to you today, I don't think it's a good idea for you to do the balance assessment. Yes, if it is 4 weeks or 5 weeks or 6 weeks post an ankle sprain, then I think it's a good idea. And even if it's an ankle surgery, not a good idea to do 1 week post surgery, again 5 or 6 weeks. And those are areas. So when a patient has had an injury, when the patient has had a surgery, you would first focus on the range of motion. That's your main concerns. You would focus on the strength. That's your main concern. Balance, proprioception, and all the other things, let's say tightness and everything, that comes later. The main concern, so the main few first initial assessment, the main initial few weeks, you would be more focused on the range of motion and the strength and the sensation and things like that. All right. Functional assessment, so you would have to check how the patient is squatting. Now, again, for the functional assessment, you do not have to do everything that I've written here. All right. It's just an example. So let's say the patient is having low back pain. You would have to see how the patient is squatting, right? Or the patient is having a knee issue. So you would have to see sit to stand, for example, or a lunge. Knee to wall test is an indication of the dorsiflexion range of motion. So again, ankle sprain, ankle surgery cases. I have not included it here, but and I remember talking about it in the hypothesis slides, that you would have to check and assess whether the patient is able to move his hand at the back. So, in case of shoulder cases, is he able to close the strap? And that was one of the questions in the subjective assessment. So, you would have to assess it, you would have to check for that. Are you able to move your right hand at the back towards attempting to close your bra, something of that sort? Or are you able to reach for your hair as if you're going to comb your hair? So these are things that you would be checking in an upper limb. Squats, sit to stand, lunges, knee to wall assessment is for lower limb assessment. All right. Again, it is very important to be specific to what the patient's concern is. If the patient has come to you for a shoulder injury, there is probably no point in you doing a squats assessment or a sit to stand or a knee to wall check, especially in the first assessment. And that is the only one assessment that you would be doing in your exam, right? Later on, if the patient is an athlete and he is, or an older patient who has been falling, later on, if the assessors ask you what are your future plans, that is something that you can tell. But for the exam day, that is not your priority. All right, I hope it makes sense. So what I'm trying to say is, you are going to be very, very specific to why the patient is here. What has brought the patient here today? If the patient has pain in his hip, makes sense for you to do a squats assessment or sit to stand assessment, and two is enough. If the patient has pain in his hip, does not is not necessary for you to do, all right, can you show me if you're able to move your hand up to your hair? Does not make sense. So be very mindful and use the knowledge and your common sense when you are doing the assessment in the exam. And I would highly encourage you to practice mocks. Please let me know if you need any help with doing the mocks. I am happy to conduct a live session and I'm happy to do some mocks. Um, but please make sure to practice as much as you can. And all these things will make more sense when you have practiced just before you have your exam. And also remember that these things should come in a flow. You should not, you will not have time to think in that 50 minutes. You, it should be just so prompt, so back to back, that it should be like how you would get up and get ready for your work in the morning. So you know that you get up in the morning, you have to brush your teeth, and whatever you do. So it's very automatic. The same way in the exam, it has to be very automatic. You do not have time to be thinking, okay, after posture, what was it position of the limb, what is it, redness? And it is okay if the redness is observed later and you assess the swelling first. It's okay, right? But ideally, the posture should be the first. Position of the limb, swelling, deformity can be interchanged. Walking assessment, functional assessment. That's how it should be. All right, moving on. Second part is your palpation. In this part, you would be touching the patient. So remember to take consent before touching the patient for the palpation. So this is the third consent that I was talking to you about. Just don't say, okay, let me feel around your joint. No. So let me give you a bit of background. The patient is sitting in the wheelchair. You have done the posture assessment. You have made him stand. You've made him walk in the room, and then you make him lie down on the plinth. All right. So the palpation and the examination component, I would highly recommend and encourage and suggest for you to be done on the plinth. Make sure that the patient is comfortable. All right. Now, before, let's say the area that is involved is your right knee. So before you touch the right knee, you would say, all right, now we are going to be starting the second component of the physical examination. And in this part, I will have to move my hands around your right knee to see where exactly the concern is. And I would have to also compare it with the left knee. Is that okay? So you've taken that consent before you touch the patient. All right. So what are you checking? Our area in this case is the right knee. All right. So from the back of your hand, you are checking for temperature. You are checking for tenderness, areas of tenderness around the knee joint. If the patient has had a surgery and has not walked in a long time, you would be checking for DVT. So when you're checking for DVT, you are just stroking your fingers on the back of the leg, that is the calf area. And obviously, you've already checked for redness. You are checking the temperature with the back of your hand on the calf area. Muscle spasm, when you are moving around, when you are moving your hand on around the knee, the right knee, you will have to check for muscle spasm on the quads. Again, as I said, if it is a female patient, be very careful how you are touching the patient. Do not make the patient uncomfortable. And also, let's say the patient is wearing pants, it would be a good idea for you to ask them to move their pants up or roll their pants up. Do not do it unless the patient asks for help. All right. So let's say you want to look at the right knee and the patient's knee is covered. And my apologies, I should have spoken to you about this before we start the observation. So if the area that you need to assess is not well exposed, tell the patient, I need to look at your right knee, but you're wearing pants. Is it all right if you roll your pants up? The patient says, yes, that's okay. If the patient is wearing shorts, it's not a problem. All right. Now, let's say you have to assess the back. The patient may have to remove their shirt. So always take consent. Is it okay if I want to have a look at your back, at the lower back specifically. So is it okay if you remove your shirt? And are you wearing any singlet under? So the patient says, yes, that's okay. So the patient is okay. Let's say the patient says, no, I don't want to remove it. That's okay. Not a problem. How about you lie down on the plinth on your tummy, and I will move your shirt up and I'll give you a towel to cover your back, the areas that I do not need to assess. Is that okay? So the patient says, okay. Make sure that you make the patient feel very, very comfortable, and their dignity is very important. All right. So just expose the areas that you need to assess. So we were talking about the right knee. When you are assessing the right knee, you would also have to assess the quadriceps and the hamstrings probably. So make sure that you again take consent. So I'm just going to move my hands on your thigh, and I'm feeling for this muscle bulk, which is the quadriceps. Is it okay? So you are using your two fingers and you are moving on the middle part of your thigh, the lateral part of the thigh, and the medial part of the thigh. So you are assessing for different muscle groups of the quadriceps. If you have to assess the hamstrings, let's say it's a hamstring tear case, so you will have to make the patient lie down on their tummy, that is in a prone position. Again, cover the part, so cover around the hip and the back area, make the patient feel comfortable, take consent. All right, I'm just going to move my fingers on the back of your thigh, and I'm feeling for your hamstring muscles, which is the area it is affected, and I will be comparing it with your left side. All right, again, verbalize, just don't, and take consent. Just don't start poking your hands anywhere on the patient. Please don't make the patient uncomfortable, even if it's not a real patient. You have to imagine, you have to believe that you are assessing and treating a real patient. All right, we are assessing for bony prominences. Again, referring to the Ottawa rules, if there is any pain on the lateral malleolus, medial malleolus, or the fibular head, you are assessing for that. You are assessing for the joint line, looking for maybe meniscal injuries, and yep. Moving on, the crepitus. So crepitus, let's say the patient is come to you with a flare up of arthritis. You've already understood that from the subjective assessment. When you were doing the observation, you have confirmed that because you can see some redness, you can see some swelling as compared to the other side. Now you are going to be moving and seeing if there's any crepitus. So crepitus can be included in the examination component if needed, but it's okay to be putting it here. You could also feel for patella movements, and again, we are thinking about a flare up of patellofemoral arthritis, let's say. So you're feeling for crepitus, you are feeling for how stiff the patella is, and that can be included in the palpation component. All right, examination, the last component of your physical examination or your objective assessment. You again taking consent. So verbalize what you have found in the palpation. So I can see that your temperature of the right knee looks okay. I can see some tenderness. I can feel some tenderness around the lower part of your knee, around the patella. And I can feel the bony prominences, but they are not too tender. So that's good. Let's move on to the last part, that is I would be moving the right knee, if that's okay. If it gets too painful, please let me know. But before I move, I want to see how far you are able to move it. Okay? I would be comparing the right and the left sides. Is that okay? All right. So we are talking about the right knee, my friends. What I want you to do is, Mr. X, I want you to slide your right heel towards your bottom, right bottom, as far as you can. One way of saying it. So we are checking for knee flexion. Or what I want you to do is, I want you to bend your right knee as far as you can. So when we are doing the assessment of the range of motion, the first time when you are doing it, you are not going to put the gonio on the patient. All right. So the first time you do it, you just observe. So you are checking for knee flexion. The patient is moving their right heel towards their right bottom. Just see how far is the patient able to move. All right. You can start from the good side. In this case, you can start from the left side. So just observe how far is he able to move. Let's say 90 degrees. That is the patient's normal. So that is the patient's normal, because we are not going by the textbook definition of 120 degrees or 180 degrees of shoulder flexion, let's say. w- we are comparing the patient's normal, and the patient's normal is your good side range of motion. All right, I hope I'm making sense. So the patient's concern here is your right knee. We are checking for the left knee range of motion, that is the good side. So we are seeing whether the patient is able to move his right heel towards his right bottom, or left heel towards his left bottom, or can you slide your left heel onto the bed. So check the good side, then check your affected side. All right. In the exam, how would you say it? All right. So we are now going to be starting with the last component of the physical examination. And in this area, we are going to be checking how well you are able to move your joints. All right. So let's start with your left side. That is the one which is not in trouble. And for the testing purposes, we will refer this to as the good side. Is that okay? All right. So what I want you to do is, I want you to slide your left heel towards your bottom. All right. So I can see that you are able to move it to 0 to 90 degrees. That's good. Let's try this now on the painful side. That is your right side. All right. How far are you able to move it? So again, we are just observing in the first try. Okay. All right. Thank you. Please straighten it. Now I have this instrument, second attempt. I have this instrument which we call the goniometer, and I'm going to place it on the outer side of your knee. So specify to the patient where you are going to keep it and why you are using it. This is for me to be able to have a proper estimate of your range of motion. Is that okay? All right, do not worry about the name, the goniometer. Okay, so again, starting from the left side, that is your good side, putting it on the lateral malleolus, stationary arm in line with the femur, moving arm in line with the fibula. All right, so I want you, what you have done in the first trial, I want you to slide your left heel towards your bottom. Again, this is active range of motion testing, so you are not forcing the movements. You are just following the patient's movement, but this trial, you are just measuring it. So The first trial that you did, you had an estimate with your eyes. Second trial is your gonio assessment. All right. Compare it with the affected, that is your right knee. Okay. Again, I want you to slide your right knee towards on the bed, or slide your right heel towards your right bottom. And I'm going to use the goniometer again. You should be knowing about the landmarks. Please, you don't have time to think in the exam. All right. Now you have a documented estimate, not an estimate. You have a documented number, 90 degrees, 0 to 90 degrees on the left, 0 to 60 degrees on the right. All right. So the patient's normal is 90 degrees. So you have a deficit of 30 degrees of knee flexion on the right side as compared to the left. All right. Now, the third trial, you would be passively moving. So, how will I tell the patient? All right, so this is going to be the last time we are going to move your knee. And this time, I want you to relax completely. I am going to move your knee. Is that okay? You come to the left side and always do not try to reach for the patient's left knee whilst you are standing on the right side. So, when you are assessing the patient's left knee, go towards the left side. When you are assessing the right side, come to the right side. Okay. Now we are going to be doing the third trial, that is the passive range of motion. And I want you to relax completely. So you are standing on the patient's left side. You hold the one hand on the patient's heel. um, I would say I'm standing on the patient's left side, so my left hand would be on the patient's left heel, and my right hand would be on under the patient's knee on the popliteal fossa. So I'm supporting, and you move your hands up as you go into flexion over the patella, and then straighten it or extend it, and your hand comes under the knee on the popliteal fossa. All right. So if you have any problems, please let me know. I'm happy to make practical demonstration videos, or again, as I said, I'm happy to conduct live sessions to show you how we are going to do it. But obviously I cannot do it. I'm just assuming that you guys know what I'm talking about. But please get back to me if you have any concerns so that I can help you to the best. All right. So I'll quickly tell this again. When we are doing the active and the passive range of motion assessment, we are checking three trials, and these three trials are just for the affected area. All right. So the affected joint in our case, which I was talking about, was the right knee. So we are first going to have an estimate. That is the first trial wherein we do not place the goniometer. We check the left knee, the good knee, estimate it. Then we check the right knee, estimate it. Then we put the gonio on the left knee. Then we put the gonio on the right knee. The third and the last trial, we passively move the left knee. Then we passively move the right knee. All right. The examination of the affected joint should also include assessment of the joint above, that is the hip and the ankle. All right. How would you do that? So the three trials that I was talking about has to be done only for the knee, that is your affected area. For the hip and the ankle, you do not have to do these three trials. And you do not need the gonio. And you don't need the passive range of motion. All right. So you would just say, I want to check the joint above, that is your hip joint of the left side first. So, are you able to move your knee towards your chest as far as you can. So we are checking for hip flexion. All right. I am now going to be checking the right hip. So are you able to repeat the same movement on your right side? Oh, good. Now let's check your ankle. So are you able to bring your foot towards you on the left side and away from you? Good. Are you able to repeat the same thing on the right? Bring your foot towards you. That's ankle dorsiflexion. Foot away from you. Ankle plantar flexion. When you have checked the hip of the left side, hip of the right side, ankle of the left side, ankle of the right side, then you come to the knee of the left side, knee of the right side. That is our affected area. All right, so I'll quickly tell you when you begin with the examination, that is the last component of your objective assessment. We are going to be starting with the joint above the affected area on the good side, joint above of the affected area on the affected side, joint below the affected area on the good side, joint below the affected area on the affected side, joint affected on the good side, joint affected on the affected side. All right, let me give you another example. The patient is having tennis elbow on the left side. So we have to assess the shoulder, we have to assess the wrist. Left side is affected. So we begin with the right shoulder. We then go to the left shoulder and we are just checking the movement. How far are you able to move your right hand up towards the ceiling? All right, let's try it on. And you are demonstrating what you want the patient to do. So we are checking for shoulder flexion. You are standing in front of the patient and you are telling him, I want you to move your hand up towards the ceiling like that. So you are telling the patient what you want to do. So our left elbow is affected. We are checking the right shoulder flexion. We are then checking the left shoulder flexion. Then we come to the right wrist flexion extension. Then we come to the left wrist flexion extension. Then we come to the right elbow flexion extension. Three trials: estimate, compare to the left side, estimate, elbow, measure with the gonio, flexion extension on the right, measure with the gonio, flexion extension on the left. Passively move the right, passively move the left elbow. Okay, I hope it makes sense. Please, I'm trying to help you guys to the best of my capacity. If you think that you need more help, if you think that some part of the assessment is not making sense, please feel free to leave a comment or email so that I can try answer your questions and help you. All right. Now, moving on, we do the strength assessment, the strength testing. Now, if the patient is in lot of pain, he may not allow you to do the strength testing, and that's okay. And that's perfectly fine. All right. If the patient is able to move and he allows you to do active range of motion testing, but when you do the strength testing, because the patient is in a lot of pain and you can't do it, it's okay. And you would know that when you are moving the joint. Let's say the patient has had an ankle sprain, right side, and you are trying to assess the right ankle, and you ask him, okay, I need to check the movements, are you able to move your foot towards you? And the patient said, no, 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 I'm in a lot of pain. So you're not able to do the range of motion testing only. How would you do the strength testing? You cannot do it, right? So again, these are steps. So you do the active range of motion testing first, then you do the strength testing. And if you are not able to do it, it's okay. You can tell them, that's okay, I am not able to do an assessment of your strength because you are in so much pain, and that's fine. We can do it next time. All right. I hope all of you know about the strength testing grades 0 to 5 MMT. Try not to complicate it, plus 5, plus 4, minus 4. To be honest with you, I get a bit confused. So I preferably stick to the numbers and keep it very simple in the exam, rather than showing off my excess knowledge and then putting myself into trouble. I would not do that. Okay, sensation check. Again, not necessary for you to do it. Only do it if the patient has told you in the subjective assessment that the patient was feeling some tingling sensation or some reduced sensation on the legs or the shoulders or whatever. Only then you need to do it. Dermatome wise checking would be done if the patient has having some neck pain and then complaining of tingling and numbness coming down to the hand or the wrist. Otherwise, you can just do a gross sensation check. So the sensation, there would be tissue paper in the room. How would you do it? You take the tissue paper and you would say, all right, we are now going to be checking for your sensation, because you told me during the subjective assessment that you feel a bit reduced sensation on your right side. So this is a tissue paper. I'm going to stroke it on your forehead. Can you feel this? The patient would say yes. All right. Now I want you to close your eyes, and I'm going to stroke it on different areas of your right and your left hands. Please let me know if you are able to feel it and if it feels the same or different. So you just randomly stroke on the biceps, right biceps, compare it with the left biceps, left triceps, comparing it with the right, and so on. And if the patient says, no, the right side feels a bit different from the left. All right. Can you please open your eyes? If the forehead sensation was 10 out of 10, how much would you rate this sensation? The patient would say, maybe 3. Okay. So then you would say, all right, I'll put a note for your nurses, or I'll put a note for your carers, to make sure. And also, please make sure that whenever you are in the kitchen, be careful, because you have reduced sensation on your right side. Make sure to be very careful when you are doing things in the kitchen, or when you are going to have a shower. Make sure to check the temperature on your left side first before you pour water on the right. All right, calf length testing, again, not to be done in all the cases. If the patient complained, if the patient's concern or the area that we are treating today is the lower limbs, and you have made the patient walk and you see that the patient is walking on their toes, at that time, yes, you need to do a calf length check. You can do the you can do that in a supine lying position, or you can just ask, if the patient is sitting, you can put their leg on your thigh, and then you can do it. I prefer doing it when the patient is on the plinth. All right. Now, coming to special test. Now, as I told you before, do not use the term special test. I have just put it here for you guys to understand. Special test, you do not have to do 10,000 tests. You just have to do 2 maximum. And it's not necessary to be done in all the cases. Also, just tell to the patient, all right, I've seen how your joints are moving. Now I'm just going to do 2 or 3 tests to confirm the probable diagnosis, or to confirm um, my assessment. Is that okay? Do not use the word special. The patient would just feel, oh, what special means, and you will not have time to answer a lot of questions if the patient starts asking you in detail about what does special mean. So it will be a waste of time. So just avoid using the word special. Okay, so this is for differential diagnosis. For each specific joint, just try to remember two, maximum two tests, or three. That's it. For shoulder, three special tests. For knee, three special tests. You may not require to do the special test in all the cases, but if you do, just as a backup plan. Okay, so we have done the observation, we have done the palpation, we have done the examination. Now what? Explain your findings to the patient in simple terms. How would you do that? So, I believe a good idea is to explain your findings as you go. So, as you are observing, keep verbalizing. As you are looking, keep talking to the patient. As you are moving, keep telling them what you are feeling, what's happening. As you are palpating, keep telling what you are feeling. All right. And again, observation comes first, then comes the feeling, the palpation, then comes the examination. For the examination, when we are doing the active range of motion testing, we are assessing the joint above, assessing the joint below. For the affected joint, we are assessing them 3 times. First is an estimate, second is the gonio, third is the passive range of motion. Okay, explain your findings. So briefly summarize what you have found. So I'll quickly summarize what I have found from the physical examination. I can see that you have some restriction in the range of motion of your right knee as compared to the left. I could also see that there is some swelling and some redness around your right knee. So, based on this, I would like to plan your treatment. But before that, we were discussing about your goals. So, if you have not discussed about the patient's goals, or if the patient just gave you some vague goals and you have said to the patient, we will come back to these goals later in the assessment, make sure to come back to the goals now. Now is the time to negotiate and rediscuss the goals before you start the treatment. There is a criteria in the APC exam wherein whether you have negotiated the goals and whether you have set your goals. If you get a no there, then if even if you have done a good subjective, you have done a good objective, you would get a no in your treatment part. So the goal setting is very, very important. So, after you have done your objective assessment, explain the patient what you have found, renegotiate, rediscuss the goals, and then again take your consent, your fourth consent for the treatment. All right. So, l- let's begin with the treatment. So, is it okay if we focus on this, and this for today's session? I'll give you an example. The patient's concern was the right knee. The patient has had a flare up of arthritis. He has come to you. He's got some x-ray done which says that there are arthritic changes indicative of tibiofemoral arthritis, and the patient has been having difficulty to walk for long distances, and the patient's goal is to run a marathon. So You negotiate the patient's goals. All right, running a marathon is probably a long term goal, but for today's session, how about we try and set let's try and see if we, for today's session and the next few weeks, how about we try implementing a walking program that you can do 2 to 3 times during the week, and then we will gradually progress it. Remember, we have already talked about the smart goals, so if you have any concerns about the goal setting, please go back there, the previous slides. But so again, the no, sorry, tibiofemoral arthritis. So we are going to be discussing about that. Okay. So I'm going to tell you how you would tell the patient. All right, Mr. XYZ, I have assessed your knee and the right knee, which is your main complaint for today. And based on the X-ray report and based on my assessment, I can see that there is some limited movement, some restriction in the range of motion of your right knee as compared to your left. For today's session, how about I teach you some exercises that will help to improve the range of motion of your right knee, and also I can teach you some strengthening exercises for your right knee. This will help you to achieve your short term goal and your long term goal of walking and maybe running a marathon in an year or so. Is that okay? Are you happy for me to proceed on these two areas for today's session as the treatment? The patient says yes. Okay. So, what are we doing? All right. For the patient is lying down on the plinth. Let's begin with the range of motion exercises. So, you know about the range of motion exercises. I'm assuming for the knee, I want you to straighten both your legs. And when I was talking about the range of motion, I said 0 to 90 degrees or 0 to 60 degrees. So I'm assuming that there is no extension lag. So the patient knee is in full extension. Okay. So what I want you to do is I want you to straighten your right knee and slide your heel towards your bottom. All right. So let's say let's start. Okay, so let's say the patient is able to do it 8 times. So you, how would you count? Slide your heel towards your bottom, one. Patient straightens it, again slide your heel towards your bottom, second count. Straighten it, slide your heel towards your bottom, third count. Straighten it, slide your heel towards your bottom, fourth count. Straighten it, slide your heel towards your bottom, fifth count. And the patient says, oh, I can't do anymore. That's okay, have a rest. Okay, so how many repetitions the patient has done? 5. Stop there. Give the patient rest. I know all of you would be on a time constraint during the exam, but the number of repetitions that you give as a home exercise program has to be based on what the patient can do, not what you want the patient to do. And there is a big difference. The number of repetitions that the patient is given as a home exercise program should be based on what the patient can do. And in this example that I was telling you, the patient can do only 5 repetitions. So you do 5 and stop. The patient is having a rest. Why? We do not want to aggravate the patient's pain, and we do not want to give him an exercise intensity that we have not checked. All right, so now we ask the patient, how are you feeling, Mr. XYZ? Is your pain settled now? Do you think we can do another 5 counts? One example, the patient says no. Okay, that's okay. We will stop. Second example, the patient says, yes, we can try for another 5. All right, that's good. Let's try. So again, slide your right heel towards your right bottom. 1, straighten it. Slide your right heel towards your right bottom. 2, straighten it. Slide your right heel towards your right bottom. 3, straighten it. I'll let you do the other 2 by yourself. Okay, so the patient is doing it. Sliding heel towards bottom. Very good. That's the 4th count. And let's do one last one. Sliding your heel towards your right bottom. Good. All right, Mr. XYZ, that was very good. What you have done, we have done 5 repetitions and we have done them 2 times. So I want you to do this exercise 5 repetitions at home, have a rest, then do another 5. So this becomes total of 10 repetitions. Okay, I want you to do this once in the morning, once in the afternoon, and once in the evening. Okay, now this exercise was for improving the range of motion of your right knee, as we had decided for our goals for today. The second exercise that I'm going to teach you will help to improve the strength of your quadriceps muscle, that is the front of your thigh, which I noticed was a bit weaker as compared to your left side. Is that okay? So we keep a towel roll under the right knee. I want you to try and push down as much as you can onto this towel roll. All right. So we put the towel roll there. Now I want you to hold it for a count of 10. How do you count for a count of 10, guys? Listen to this. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10. Do not do the counting like 1 and 2, 3, 4, 5, 6, 7, 8, 9, 10. No. It's assumed that it is 10 seconds hold or 10 counts hold. So if it is 10 seconds hold, it is 1 and 2 and 3, or you could say 1 elephant, 2 elephant, or you could say 1 dinosaur, 2 dinosaur, whatever you want to say. But if it is 10 seconds hold, this is how you have to count. If it is 10 counts, then you can say 1 and 2 and 3 and 4. I would preferably tell you to say 1 and 2 and 3, or 1 elephant, 2 elephant, like that, or 1 dinosaur, 2 dinosaur, like that. And the reason, I hope all of you know, based on documented guidelines, that what is the duration of the time that the patient has to maintain the joint or the muscles to be able to achieve the results in the strength improvement. All right. So let's say the patient is able to hold for 10 seconds. You give them 10 seconds of the static quadriceps. Then you say, all right, please stop. These are the 2 exercises that I want you to do at home. The first exercise, as I told you, would help to improve the range of motion of your knee. The second exercise would help to improve the strength of your quadriceps muscle. Other than that, I would want you to incorporate a walking program. I want you to try starting going for short walks, let's say for 50 meters outside your home once in the morning. And next week onwards, we will see how you are progressing. We will progress that. Do not worry, I will write all this information down for you, but I'll quickly summarize it for you again, Mr. XYZ. We are doing two exercises. One is your knee bending and straightening, five repetitions, then we rest, we do another five. Once in the morning, once in the afternoon, once in the evening. The second exercise is keeping a towel roll under your right knee. We hold it for a count of 10 seconds. Do it once in the morning, once in the afternoon, once in the evening. Is that all right? And the third thing, we are incorporating a walking program. These three, we are not um, rushing into our treatment. We are incorporating these small steps so that we can achieve our higher goals. But for the commencement, or just to begin with the session and make sure that we are not overloading the knee, I would suggest to start with this program, and then we will modify it when you come and see me next week. All right. Now, guys, I'm coming back to these slides. So we have explained the findings, we have discussed and negotiated the goals, we have planned a treatment, include 2 to 3 exercises, as I said, explain the purpose of the exercises, how will it benefit to the patient, how many reps, sets, times in a day. So exactly what I was doing before. I've explained you that what is the purpose: increase the range of motion or improve the strength, how many times um, in a day, how many reps, and what is the home exercise. How is the patient going to do this home exercise program at home? Now, the example that I gave you was knee range of motion exercise when the patient is in supine lying. If the patient has a very good functional capacity, you would not like to give the same exercise if the patient is, say, 60 years old who is very active. There's no point. So, your treatment would be based on the functional capacity of the patient. All right. Let's say if the patient is already running, or if the patient is not running, actually the patient is already walking for 100 meters without having an aggravation of his pain, then there is no point in you making him walk only for 50 meters, right? So the point is, direct and modify your treatment based on the patient's capacity, based on the patient's capability. All right. If the patient can do exercises, or he's already walking around, and is a very fit person, then you may want to give the exercises maybe in standing, right? So you can give, let's say, squats, or sit to stands, or what do you say, heel raises, whatever. The point is, modify your treatment and the exercises that you would give depending on the patient's presentation. What I did was I created an exercise template with 3 exercises in sitting, 3 exercises in lying, and 3 exercises in standing. So the standing exercise, obviously, you can modify depending on, you can give weights, you can give therabands, you can do that in sitting as well, but I preferably use therabands and ankle weights only if the patient is standing. So at least the strength is 3 plus, you know that for sure, right? For the lying exercises, you can do them, you can increase the number of repetitions. Some patient may be able to do 10 repetitions, some patient may be able to do 5. So give the exercises, as I said, depending on the patient's capacity. Do not give a number randomly. If you have done 5 repetitions, tell him to do 5 repetitions at home. If you have done 10 repetitions, tell the patient to do 10 repetitions at home. All right. For the purpose of the exam and the purpose of time constraints, I would suggest giving the same home exercise program. You do not have to choose different home exercise program for the patient. All right, the last two things, we revise the treatment plan to the patient, to revise what we have done. So, based on the assessment and based on your goal is to run a marathon in the next 1 year. But your short term goals, we will work on improving your walking distance and to wean you off the crutch, let's say. And we have started with the range of motion exercises and strengthening exercises, and we will progress it accordingly. Do you have any questions, Mr. XYZ? No, I will ask you um, to have a rest now, and I will get you the home exercise program written so that it's easier for you to remember. All right? Thank you. That's it. That's how you would do the hypothesis, the subjective, and the objective assessment. That's it. That's it. I hope it made sense. Please, please, please let me know. Email or leave a comment if you would like me to make slides on the treatment part, or if you are having any specific difficulties in the treatment part, and I'm more than happy to address your concerns and talk to you about that and try and help you. I really appreciate all of your time to look at the videos, and I hope they are being helpful. These are the references, and that's it. Thank you. Thank you so very much. I will see you in the next one.